Well, you made it. Welcome to the grand finale. I am absolutely thrilled to have you here for part 15 of our Interventional Radiology Coding Masterclass. Look, if you've been with us on this journey, I just got to say right out of the gate, congratulations. You stuck with it, you did the heavy lifting, and you have officially mastered the core principles of vascular IR coding. Today, in this final explainer, we're literally bringing everything together with a super satisfying multi-branch visceral case study. It's going to be great.
So here's our roadmap for this final puzzle. We'll start with our welcome to the finale, then dive into the clinical scenario, break down the catheter placement logic, unpack the radiological imaging breakdown, give you the final code summary, and finally, do our masterclass wrap-up. We're taking an operative report and deconstructing it step by step from the very first clinical action all the way to the final code.
Let's kick things off with Section 1. Welcome to the finale, Mastering Interventional Radiology Coding.
You know, mastering interventional radiology coding, it's honestly no small feat. It takes a really deep understanding of anatomy, a laser-focused grasp of procedural techniques, and, of course, a sharp eye for the rules that govern how we report these complex interventions. Over the last 14 parts of this masterclass, we've basically navigated coding pathways that are just as intricate as the actual human vascular system. We've tracked arterial families, mapped out venous structures, and learned the specific rules of engagement for every tiny little branch. Today is where we put all that navigational skill to the ultimate test.
Moving right along to Section 2, the clinical scenario, right femoral to splenic artery. Okay, let's walk through the actual surgical steps chronologically. So picture this. The physician starts with Step 1, gaining access right at the groin via the right femoral artery. From there, the catheter gets advanced way up into the high abdominal aorta, and they perform an initial aortogram. All right, now Step 2. The catheter is actively engaged into the celiac artery, and they inject contrast to image the celiac distribution. Moving on to Step 3, they push that catheter even further, advancing into the common hepatic artery for some additional selective imaging. And finally, in Step 4, the physician pulls back, withdrawing the catheter from the common hepatic and repositions it, selectively placing it into the splenic artery for yet another round of selective imaging. Think about that physical path for a second. Up the aorta, into a main trunk, down one branch, back out, and then down another completely different branch. It's like navigating a complex highway system.
Just to really ground ourselves, let's quickly remember exactly where we are in the body. We're working squarely within the visceral arteries. These are those absolutely crucial blood vessels branching right off the aorta, delivering blood to our internal abdominal organs. In this specific scenario, we're navigating the branches that supply the liver and the spleen. And this specific visceral distribution, that forms the absolute foundation of the procedural coding we're about to deconstruct today.
Next up is Section 3, catheter placement logic, applying the golden rule.
All right, let's isolate just the physical catheter movements. We're going to assign our first set of codes based purely on where that catheter tip was actually placed. The vascular family hierarchy really maps out perfectly for us here. First, the celiac trunk is engaged. Now, as we know, the celiac trunk is a first-order vessel, and it sits below the diaphragm. But our physician didn't stop there, right? They kept going and advanced into the common hepatic artery. That move makes the common hepatic a second-order branch also below the diaphragm. But wait, remember Step 4. The physician withdrew and then steered the catheter into the splenic artery. Now that splenic artery represents a second or additional second-order branch. And here's the kicker. It lives within the exact same celiac family as the hepatic artery.
So this right here is where we have to apply the absolute golden rule of interventional radiology coding. Because two totally different branches were selectively accessed within the very same vascular family, we need one primary code plus an add-on code. It's that simple. On the left side of things, we report our primary code, 36246, to capture that initial second-order branch below the diaphragm, the common hepatic artery. Then, on the right, we absolutely have to bring in our add-on code, 36248, to report the splenic artery. Why? Because it's an additional second-order branch, accessed within that exact same celiac family. It's elegant, it makes total logical sense, and it perfectly captures the physical work the physician performed.
Let's transition to Section 4, Radiological Imaging Breakdown, SNI Splitting.
Okay, So we've got our physical catheter placement codes totally locked in. But now we've got to pivot. We have to shift our focus from the physical tube to the visual component. Diagnostic angiography is all about visualizing these blood vessels by injecting contrast dye, right? Well, every single time that contrast is injected for a distinct anatomical evaluation, in this scenario, we have to account for it with specific imaging codes. Basically, we can't just code for the tube itself, we have to code for the pictures they take through the tube.
Let's map this out nice and clearly. First off, the physician injected contrast into the celiac distribution. For that initial visceral angiogram, we're going to report the base code 75726. But they didn't pack up and go home after that. They took additional, selective shots. When they imaged the common hepatic artery, we report the follow-up angiogram code, 75774. And then they took another totally distinct set of images over in the splenic artery. What does that mean? It means we report 75774 again. So when all is said and done, for those additional selective follow-up angiograms, we report 75774 times 2 units.
All right, here we go. Section 5, Final Code Summary, the complete operative string.
We have successfully deconstructed the physical journey of the catheter, and we've mapped out the radiological imaging. Now, it's time to bring the whole shebang together. Our complete operative string for this incredibly complex multi-branch procedure comes out to a really beautiful block of 4 specific codes. We start with 36246 for the primary catheter placement in the hepatic artery. Then, we tack on the add-on code 36248 for that additional placement into the splenic artery. We pair those physical codes with 75726 for the base radiological SNI of the visceral angiogram. And finally, we cap it off with 75774 times 2 units to capture the distinct, selective follow-up imaging in both of those second-order branches. Boom! The clinical scenario translates absolutely flawlessly into this exact coding sequence.
And that brings us to Section 6, Masterclass Wrap-Up, Celebrating Your Core Competencies.
You know, it is just so incredibly important to take a step back and reflect on everything you've achieved since we kicked off this explainer series way back in Part 1. Just look at this checklist of core competencies you now have under your belt. You have completely mastered anatomical vascular families, arterial, venous, visceral, extremity, you name it. You've learned how to confidently navigate the seriously complex appendix L hierarchy. You easily distinguish between codes used above versus below the diaphragm. You execute SNI splitting seamlessly, knowing exactly when to pull the physical work apart from the imaging. And perhaps most importantly, as you just proved to yourself today, you can expertly deconstruct dense, confusing, multi-vessel operative reports into perfectly accurate compliant coding strings. You should honestly feel so empowered and incredibly capable right now.
You are officially ready to tackle the absolute hardest coding scenarios out there. So as you take these highly specialized skills back to your own clinics and hospitals, I want you to ask yourself, what complex vascular puzzles will you conquer next? Thank you for watching, and keep learning with Decode Healthcare with Harshal.